Right. Thank you.
Sarangani, shall we start then?
Yes, sir.
Okay, right. Hari. Hari. Okay, so yeah, so fine. So we will do two sessions, so one today and one tomorrow. Okay, and essentially the focus is going to be on interpretation of investigations. Okay, so we do ECG today and X-rays tomorrow. So X-rays include chest X-rays and other types of X-rays that might be important to you. I usually do this with the clinical appointments, but because you guys are just staying at home doing nothing, I think this is important. And then we can obviously revisit this when you come for your professorial appointments. Okay, fine. Right. So let's start with ECG. So again, as we go on, if you have any questions, comments, problems, please put it on the chat. Okay. Right now, this discussion or lecture is going to be structured based on these 6 points. Now, the first thing we will do is we will get a basic knowledge of ECG leads. Now, here we are referring to the standard 12 lead ECG. So let's learn that first. That's quite important, right? Then the other 5 points are the sequence in which you should look at any ECG, right? You should look at any ECG in this sequence. හරි නිකන් ECG කරලා නිකන් අර මෙහෙම කළා මෙහෙම බලන්නේ එහෙම බෑ, right? So you can't do that. As a medical student, you have to go through all these steps. It's only if you do that that you will be good at looking at ECGs, right? So there are 5 steps to look at an ECG, right? Or interpret an ECG. The first thing is to calculate the rate, right? And standard, or most of the time, we calculate the ventricular rate, right? The next thing to do is look at the ECG in general to decide, is this rate regular or irregular? Okay, so that's also quite important. Number two thing is to look at the axis. So what is the cardiac axis at the moment, right? We will talk about this in more detail as we go on, right? The third important thing when you're looking at ECG is to define the cardiac rhythm. Now, what you mean by rhythm here is slightly different from rhythm in a pulse, for example, okay? The cardiac rhythm refers to the site of onset of the predominant cardiac impulse. Okay, the main electrical activity. Where does it start? Right? Does it start in the sinus node? Does it start in the atrium? Does it start in or around the AV node? Does it start in the ventricle? So the predominant, or I would say driving electrical activity, where does it start? In a normal person, you'd expect it to start in the sinus node. But does it start anywhere else? Does it start in the atrium? Does it start in the node? Does it start in the ventricle? So that's how you assess the cardiac rhythm. And that is potentially the most sort of difficult, complicated thing that you will do in an ECG interpretation. Okay. The next thing is to look at conduction. Now, when there is origin of the cardiac impulse, obviously it has to be conducted along the heart, okay, heart muscle. And here you look at conduction problems. Is the conduction normal? Is it going down normally, right? Or are there blocks in between? So yes, first rate, regular or irregular, cardiac axis, cardiac rhythm. Where does the cardiac impulse start? Then the conduction, how is it propagated? How does it travel along the heart? And then finally, you look at individual waveforms and segments. Individual waveforms and segments. For example, P wave, QRS complex, PR interval, ST segment, right? T wave. These individual parts, you are finely dissecting the ECG now, right? Looking at individual waveforms, looking at individual segments. And that is the last thing you do in an ECG, right? You don't do that at the first. So number 1, 2, 3, 4, 5, this is very, very important. Any ECG from today onwards, you are going to look at it in this manner, okay? Rate, axis, rhythm, conduction, and then focus a little bit on the individual parts of the ECG. Individual parts of the ECG. Okay. Right. Unfortunately, I usually teach this drawing, but I don't think I can do this. I have a whiteboard, do not write on it. I don't know why. This is probably interactive whiteboard. So I don't want to get kicked out of this place. But I will try to use this figure to teach. Okay. Now, here I'm going to teach you about leads in a ECG. Right? That's the first thing we are going to talk about. Now, there are 12 leads in a standard ECG. Some ECG have more, right? You can record additional leads, but in a standard ECG, you have 12. Right. Now, what is a lead? What do you mean by the word lead in an ECG? What a lead means it is essentially a window, where you look at the heart. It is like a window from which you look at the heart. A lead is like a window that you look through and look at the heart. And when you look at the heart, this lead, when you look through this window, you can see current coming to or away from this window, right? Say you look at the heart through the window and you can see current coming to this window or away from this window. So you are the observer looking through the window, right? Current can come towards you or current can come away from you. By standard definitions, current coming towards a window or current coming towards that lead creates a positive deflection on an ECG towards the window, towards the lead is positive. Current moving away from this window, current moving away from this lead is negative. So positive, negative. Current coming to the lead is positive, current going away from the lead is negative. Okay. So there are 12 leads. And I told you a lead is like a window through which you look at the heart and the electrical activity of the heart. Right. So let's see where these windows are located. Where are these windows located? Let's start with the easy ones. V1 to V6. So you have 6 windows, 6 leads. V1 to V6 is positioned anteriorly, as you can see in this diagram. Okay. So these are your anterior leads. They look at the heart from the anterior surface. Anterior surface. They look at the heart from the anterior. So these are the 6 leads that look at the heart from the anterior surface. V1 to V6. And V1 is slightly towards the right ventricle and all the other ones progressively towards the left ventricle. So you have this in front, right in front. So V1 to V6 look at the heart from the anterior surface. Then 2, 3 and AVF, MEVA. Look at the heart from the bottom or the inferior surface. So these windows are located under the heart. 2, 3 and AVF. They are located under the heart. Inferior. So these are inferior. Then you have 1 and AVL, which are here, which look at the left side of the heart. So this lead is a window looking at the heart. 1 and AVL look from the left. From the left side. From the left side. And finally, AVR looks from the right side. Okay. So V1 to V6 are windows or leads which look from the anterior surface of the heart. 2, 3 AVF look from the inferior surface of the heart. 1 and AVL look from the left side. AVR looks from the right side. So this is how your leads are designed or located in the heart. Oriented is another word that we can use within the heart. Hari. So that is quite important. So we have gone to the first thing that I wanted to teach you. What are the leads? Lead is a window, looks at the heart from a particular point or direction, right? And I have shown you what these places are, anterior, inferior, left and right, okay? Right. Now going to axis. Okay. Now going to axis. Now usually the cardiac axis is like this. That is a normal. Somewhere there. The cardiac axis refers to a summation of the electrical activity. A level call you do this one of the vectors in here also it is a summation of the electrical activity. It gives you the general direction the current is going. Right? Then current the whole current home goes like this and all over the place. But in summary, the current goes this way. So that is a general direction of the current. So cardiac axis is a summation of where the current goes, the direction. And usually it is in this direction that I have shown. Normal axis. Okay, normal axis. So in a normal axis then, current is traveling towards 1 and 2. And also in most cases, AVL. So current is traveling towards that direction, right? So that is a normal axis. So it travels towards these leads, right? Travels towards these leads. Current travels towards these leads. So hence it is positive. It is positive. Hi. This is the positive then in a normal axis. So if you look at this ECG then, yeah. Okay, important method මෙන්න මේ දෙක. Right? They are 1 and 2. Right? Just ignore AVL for the moment. I'll come back to that. So in a normal axis then, 1 and 2 are definitely positive. They have to be positive, right? If it's a normal axis, 1 and 2 are definitely positive. So the next ECG then, this is positive. So this is a normal axis. Right. Now, okay. Now, what happens if the cardiac axis shifts to the left this way? Like that. Or this is called a left axis deviation. Left axis deviation. If you look carefully now, right, what happens to 1? 1 is still positive. The current is traveling to that lead. It's positive. Current is traveling to that lead. But 2 and 3, current is traveling away from these two leads. So 1, 2 and 3, easy, right? So what can you predict on the ECG then? If you look at just 1, 2 and 3, even AVL for that matter, right? AVL එක කලබල වෙන්න එපා. 1, 2, 3 විතරක් ගන්න. Current is traveling towards 1, so it has to be positive in left axis deviation. And you can clearly see current is traveling away from 2 and 3. එළියට යන්නේ. So it has to be negative then. So look at this figure then. You can clearly see 1 being positive, 2 and 3 being negative. So this is a patient with left axis deviation. Left axis deviation. තවදුරටත් අපිට තහවුරු කරගන්න පුළුවන් AVL is positive also නේද මේ බලන්න. AVL is also positive. That's for just for confirmation. So when you have left axis deviation, this is the direction in which your current is heading. It's going towards 1, so that's positive, but it's going away from 2 and 3, so therefore it is negative. And this ECG very nicely illustrates that. 1, 2 and 3 විතරයි බලන්න ඕනේ අපි ඉස්සෙල්ලාම මේක අමතක කරනවා. And you can see very nicely what's happening. There. 1 positive, 2 negative, 3 negative. Okay. Now the last one. What happens now if the axis is shifted this way? That is right axis deviation. Right axis deviation. And you can very clearly see, Lamai, now that current is traveling towards 2. It is traveling towards 3. So it has to be then, remember always make always current traveling towards the lead is positive, always positive, right? So they have to be positive. They come a positive when. But you can now see current is traveling away from 1, right? It's traveling away from 1. So therefore it has to be then negative. So this is a patient with, and also the other thing for confirmation would be AVR would also now tend to be positive in most cases, can be positive, doesn't always have to be positive. Positive right. So 1 is negative and 3 is positive. 2 is sort of right in the middle, sort of, but still you can see that 3 is very strongly positive, right? 3 is very strongly positive, and AVF is also strongly positive. Okay, AVF is also strongly positive. So looking at this, you can see the direction. Make positive, make a positive, make a positive. This way, AVR may or may not be positive. It doesn't have to be positive always, right? ගොඩාක්ම right එකට ගියාම තමයි මේක positive වෙන්නේ. ගොඩාක්ම right එකට යන්න ඕනේ. But here, when you go slightly to the right, then you will have these 2, 3 and AVF being positive. Right. 1 is clearly negative. 1 clearly negative now. Fine. So that is just how you would determine the cardiac axis then. Right? So what is the axis? The axis is a summation of all the electrical activity in the heart, number one. To determine the axis, මෙන්න මේ පින්තූරය අනිවාර්යෙන් ඕනේ. මේක නැතුව axis එක තීරණය කරන්න බෑ. That's why I started off by teaching you the lead orientation. So lead orientation ගත්තොත් anterior surface of the heart V1 to V6, left side 1 AVL, inferior 2-3 AVF, right is AVR. So this is the orientation of the leads, right? Normal axis 1, 2 are usually positive. Left axis, you can see that 1 will still be positive, right? As maybe AVL, but 2, 3 and AVF are negative, right? When it moves this way, when it moves that way, 2, 3 AVF are positive because it's right axis deviation. Okay, so that is how you work the axis out. Hari? Okay. Any questions so far? You can put it on the chat. Ask, switch your mic on and ask whatever you like. Yeah, just a minute for that, just to grasp this. This is very important. Without this, you cannot understand anything about an ECG, especially the cardiac axis. Make a product and the you can obviously determine where the axis is going, right? So if you have a ECG, when you're seeing positive nang, we know it's positive nang, make a negative nang, we know it is going this way. Okay. For example, if you have something like this will be positive and these will be negative. So you know it's left pattern, the right pattern, the you know, right? So you have to just draw this very quickly. You don't need to draw these angles, not very important. You just have roughly make roughly you can determine the axis. Okay, right. Okay, so I don't think it's not always the limb leads. You can use the limb leads only also, right? No problem, right? But looking at this picture, you can also use these AVL, AVF, AVRs also, right? Take a prashna, but you can only stick to 1, 2, 3 also, whatever you like. Not a problem, right? Even using 1, 2, 3, you can easily say, right? Now I'll show you that. 1, 2, 3, so positive, normal axis. Then when the axis starts shifting to the left, you know that 3 will become more negative. When it goes more and more to the left, 2 and 3 start becoming more negative. When it goes more to the right, you know that now what happens is the 2 and 3 will start become positive and 1 will be negative. So you can use the limb leads also, only also, right? A summation of electrical activity means heart anatomical. So summation of electrical activity means the sort of collection of the current, of where does the current flow. When you sort of add all the movements of the current, where does it go? That's what it means. Okay, fine, good. Right, so let's move on then. Right. Now we talk about, the next thing to do was obviously rate and axis. I'm not going to talk about rate calculation, which you already know to do. So I've directly gone into axis. Now we go to the probably the most important thing that you have to understand, right? So be very attentive in this part, right? Make a තේරුම් ගන්න. Now rhythm analysis. Now what did I say? What is rhythm? Rhythm is where the predominant activity starts. Where does the predominant electrical activity start? Now, there are several places where it can start. Obviously, one is this space. If the predominant electrical activity starts, is the onset, that's what's driving the electrical activity now. If it starts in the SA node, which is a normal place, it is called a sinus rhythm. Sinus rhythm. if the main electrical activity is in the atrium, which is in an abnormal situation, right? That's an abnormal situation. That is called atrial rhythm. So this is what's driving the heart now. Sinus may be working, but that's not material. The heart activity is driven by some abnormal activity in the atrium. Now, similarly, abnormal currents and stuff can generate here as well, which is the in and around the AV node. Okay, so that's called a nodal rhythm. Nodal rhythm. If your predominant electrical activity starts here, that's called a ventricular rhythm. So then, Lamai, there are 4 types of rhythm. When the predominant activity is in the sinus node, it is a sinus rhythm. When the predominant activity is in the atrium, it is an atrial rhythm. When it is in or around the node, it is a nodal rhythm. And when it is in the ventricle, it is a ventricular rhythm. So these are the various types of cardiac rhythms that we see in practice. Okay. All right. So just grasp that. Now say, for example, if your main electrical activity is starting there. So what is this? A sinus rhythm. The current goes very, very nicely along the atrium into the AV node and then down. No problem, no issue. Hari. So if you draw this ECG, now I want all of you to draw it, right? You get a normal P wave. What does the P wave represent? Normal depolarization of the atria. Normal depolarization atria. Then there is a delay, slight delay, because that's what it goes through the AV node and then now starts going down in the normal way in the ventricles. So I'm sorry, this drawing business is not very good on Zoom, but essentially that's the QRS complex. And then you have a normal T wave. So you have the normal P wave, normal QRS complex, and normal T wave, because the current is starting here. Now let's assume that the current is starting now in the atrium. This abnormal current, this is actually abnormal, it's not physiological. Now it's a disease where the current is starting in the atrium, not the predominant driving current is in the atrium now. Right? That is the problem. Now, what happens? Ultimately, all this current ends up there and atrium, if it starts, it current ends up there. And the rest is okay. So, Lamai, the question you ask yourself when you draw the ECG now, the QRS and T do not change. QRS එකටයි T එකටයි වෙනසක් වෙන්න හේතුවක් නැහැ, because whatever is happening down is normal. Atrium is playing nonsense, right? But whatever is happening down from that is normal, right? It follows the normal pathway, it follows the normal route. So QRS and T are normal. But do you get a normal P wave? That is the question. In an atrial rhythm, what happens to the P wave? Would you expect a nice normal looking P wave? No, because make a current not nicely. It doesn't go nicely down the atrium. It is going everywhere, right? So in a atrial rhythm, the P wave is abnormal. The P wave is abnormal, but the rest is normal. QRS is okay, T is okay. Right? P is abnormal because it's just playing socks. All the current is going everywhere in the atrium, right? Or it's starting from some other odd place, right? It's not normal, right? So the shape of the P wave is abnormal in that sense. Right. So in an atrial rhythm, then the P wave is abnormal, but the QRS and the T are normal. Okay. Now let's do the same thing here. Right. Now, who is running the show? Who is running the show now? Nodal rhythm is running the show. So he is giving stuff here. Okay. He is running the show now. But again, Lamai, it is still following the normal path there. Even though the AV node is now running the show, the current is still going down the normal route. So ventricular depolarization, which is the QRS complex, normal. T wave is normal. Because even though the node is running the show, it is sending it down the normal route. The current is going down the normal route. So QRS is normal, T is normal. Habay, what happens here now? Who is running the show? The AV node is running the show. So what happens is that. What happens there? Right? The atria are depolarized in reverse. Right? They are depolarized in reverse. And that's called a retrograde P wave. Retrograde කියන වචනේ පාවිච්චි කරන්නේ retrograde. So I will type it on the chat. Retrograde. Because it's going completely in reverse. Who is running the show now? The SA node is nonsense. It is not running the show anymore. It is there, but it's not running the show. Now the AV node is running the show. Abnormal something happening there. It is giving things down, also giving things back up. Right? So that's called a retrograde P wave. Very important right here. The retrograde P wave is very, very tiny. Very, very tiny. Extremely difficult to spot on a ECG. So in summary, Lamai, in a nodal rhythm, you don't actually see a P wave. Nothing. No P wave. Because the retrograde P wave that occurs due to this reverse depolarization is very, 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 very small. You can't see it. I'll show it to you, but it's very, very difficult. So essentially for a medical student, in a nodal rhythm, the P wave is not there. It is just the QRS and T that you will see. Right? If you look carefully, you can see this retrograde P, but it's impossible. Very, very difficult to spot. The ලේසිනේ මතක තියාගන්න. Nodal rhythm, no P. Just remember it like that. Or a very tiny retrograde P. Retrograde. Then my ATK ඔයගොල්ලන්ට කියලා දෙන්න. This is because it's so important. I'm going to spend a lot of time on this because it's very, very important. So normal current, sinus node running the show, normal atrial depolarization, normal P wave, going down node and down here, normal pathway, QRS and T are normal. Okay, fine. Current starting there. Abnormal P wave, some abnormality, which we'll talk about in a little while, some abnormality in the P wave, but QRS and T are normal because it is going in the normal pathway. සාමාන්‍ය විදිහටනේ යන්නේ. QRS and T normal. Right. If it starts here, QRS and T are normal because it goes in the normal way. P wave is absent. You can't see it. If at all, you might say very tiny retrograde P wave. Tiny retrograde P wave. Tiny retrograde P wave. Okay. Right. Then finally, what if the current starts here? What if the current starts there? Now this is going everywhere in the ventricle. Now, can you get a normal QRS&T? No, you can't. It is completely sort of abnormal. You can't get a normal QRS. It is completely abnormal because the ventricles are depolarizing in a very funny way. Very, very funny way. Now, this is again very, very important to remember. If your current is starting from the ventricle, it cannot go up. මේ පැත්තට යන්නේ current එක මේ පැත්තට යන්න බෑ. It is impossible. The current can't go in reverse. යන්න බෑ. So, but the SA node may be firing. පොඩ්ඩ එන්න පුළුවන් SA node එකේ. So, what happens is you get atrioventricular dissociation, AV dissociation. So, remember, current from the ventricle cannot go in reverse. I will show this to and explain this again, but remember for the moment, in a ventricular rhythm, right, the QRS is completely abnormal or odd shaped because it's just very haphazard ventricular depolarization. But the current can't go in reverse. The sinus node is functioning independently and is dissociated. I will explain this again. Hari. So this is essentially what you mean by rhythm. So then I summarize karanna. Sinus rhythm, normal P, normal QRS and T. Atrial rhythm, abnormal P, normal QRS, normal T. Nodal rhythm, no P or very small retrograde P because the current can go back from the node, but normal QRS, normal T. Ventricular rhythm, completely chaotic, completely funny, odd-looking QRS, and atrioventricular dissociation. Atrioventricular dissociation. That is a story. Now let's look at practical examples of these ECGs. Okay, fine. Now, all of these are sinus rhythms, right? You can see P, QRS, T. Now in this one, these are two atrial rhythms. These are two atrial rhythms. What are the features of an atrial rhythm? Abnormal P, normal QRS. The QRS looks normal to me. But the P wave is abnormal. You can't actually see a P wave. It's like the P wave is broken into thousands of pieces here. Like that. Right? The P wave is broken into thousands and thousands of pieces. So it's abnormal. Right? Why is it broken into thousands of pieces? Is that this is atrial fibrillation. This ECG I'm going to explain now. And that is because you get thousands of small currents everywhere in the atrium. Thousands and thousands of small currents everywhere. Thousands and thousands of currents. So essentially, current is going all over the place. Traffic everything goes everywhere. So essentially, the current is like this. The P wave is broken into thousands and thousands of pieces. Right. So we are talking about atrial rhythms, abnormal P, abnormal QRS. If the P wave is so grossly abnormal, it is sort of broken into thousands and thousands of pieces, creating an irregular baseline that is atrial fibrillation. So what are the features of atrial fibrillation? Irregular baseline, right? Irregular baseline, right? Normal QRS. And also, as you can see, the rate is irregular or completely irregular. So these are the features of atrial fibrillation. Atrial fibrillation. Atrial fibrillation, irregular baseline, broken and irregular QRS complexes. That's atrial fibrillation. The next ECG is atrial flutter. ECG atrial flutter. Now here you can see P waves, but it is abnormally shaped. Remember, the key thing in an atrial rhythm is that the P wave is abnormal, right? The QRS is normal. So QRS එක normal නේ අපිට පේනවා. මේකෙන් මේ normal QRS එකක් පැහැදිලිව පේනවා. Normal QRS එකක් පැහැදිලිව. But the P wave is odd shape. නේද? It is odd shape. It is like a sawtooth. Oh. Sawtooth. Sawtooth. So if you have a sawtooth P wave, that is an abnormal P wave, that is called atrial flutter. Atrial flutter. Okay, atrial flutter. In atrial flutter, the rate can be regular or sometimes irregular. Regular වෙන්න ඕනේ. In this case, it is regular. In this case, it is regular. And here you can see there are two flutter waves to one QRS. Two flutter waves to one QRS. දෙකක් තියෙනවා to one QRS. එකයි දෙකයි QRS එකයි. එකයි දෙකයි QRS එකයි. එකයි දෙකයි QRS. So that's called a 2 to 1 flutter. Right? 2 to 1 flutter. මම තව පොඩ්ඩක් flutter ගැන විස්තර කරන්නම් මෙතෙන්දී. I will just explain a little bit more here. Flutter වල වෙන්නේ you get this sort of current. නිකන් මේ circus එකක් අර merry go round එකක් වගේ current එකක් කොහොම යනවා. Goes round and round and round and round in the atrium. Right? It's like a sort of a merry go round in a circle, in a park. Right? මෙහෙම round කොහොම යනවා current එක. Right. The atrial rate can go up to about 300 or more. 300 per minute. 300 per minute වෙනකන් atrial rate can be driven by this abnormal current. But the question is, can the ventricle conduct at, or does the ventricle beat at that rate? A rate එකම beat වෙන්න පුළුවන්ද? So can it also beat at 300? The answer is no, because why? Why can't it also beat as 300? Why can't it match the atrial rate? Because of this AV node. The AV node cannot conduct that fast. So usually there is a sort of 2 to 1 delay there because of the block. So say atrium is going at 300, the ventricle will go at about 150 විතර තමයි, because the AV node is protecting the ventricle. It doesn't let the ඔක්කොම 300ම යන්න දෙන්නේ නැහැ. Rarely you can have an abnormal connection between the atria and ventricles which conduct in 1 to 1. That is deadly. එහෙම එකක you will die, because through 300 there, it goes 300 ventricles and you will die. Cardiac arrest තමයි එතන. There is no output. It's fast, so fast, right? So you will die because of no output. So some people have this abnormal connection. Wolff-Parkinson-White syndrome. In those people, there is an abnormal connection which conducts very fast. If they get atrial flutter, they will die because it conducts same 1 to 1 directly down to the ventricle, and the ventricle also goes at 300. Here the ventricle can't go at 300 because the AV node is protecting it. 300ක් આવොත් භාගයක් විතර තමයි යන්න දෙන්නේ. 300 to 150 sort of conduction rate. Okay, fine. So these are the examples of atrial rhythm. So atrial fibrillation is when you have a sort of an irregular baseline sort of thing with irregular QRS complexes, right? Abnormal P, normal QRS. Sawtooth P is again an abnormal P wave and a normal QRS. Right. Sasank, I will explain how to calculate heart rate in AF when we do a few more practical examples. I'm just teaching the basic rhythm analysis here. Right. But essentially, කොහොමද calculate? You have to go say ලොකු ගානක්. Say take about 5 complexes at once වගේ. එහෙම තමයි ගන්නේ. හරි. මම පස්සේ වෙලාවක එකක් කියලා දෙන්නම්. හරි. Right. Now look at this one. I've ignored the previous slide. I just want to show you this one. Now I just want you to look at lead 2, because actually assessing the rhythm is easiest in lead 2. Now you can see QRS looks normal. Normal. Looks okay. But can you see ඊතල ගහලා තියෙන ඒවා දිහා බලන්න ළමයි? various abnormal looking P waves. Some are tall, some are short, some are inverted. අර මොකද උසනම් security මොකද්ද කතන්දරය වගේ තමයි. සමහර ඒවා උසයි, සමහර ඒවා කොටයි, සමහර ඒවා inverted. අනිත් පැත්තට තියෙන. හරි? So here you can see the definition of a atrial rhythm is abnormal P, normal QRS. Here you can see several abnormal Ps. Several abnormal Ps. I will draw what is happening here. ECG hari අමාරුයි මෙහෙම උගන්නන්න. If you have any questions, please ask. හරිද? මම සාමාන්‍ය whiteboard එකක මේක ලොකුට ඇඳලා උගන්නන්න, but it's very difficult on this. Right. So essentially you have there. That's the atrium. This is the sinus node here. What is happening is the atrium is firing at 3 or 4 places. And that's why it's giving 3 different P wave morphologies. 3 different P wave morphologies. Right? So abnormal P waves, and there are different P wave morphologies. This is called multifocal atrial tachycardia. Multifocal atrial tachycardia. That's another atrial rhythm. So we have learned now 3 types of atrial rhythms. Atrial fibrillation, atrial flutter, and this is called multifocal atrial tachycardia or MAT. මම ආයි මේකට එන්නම්. තප්පරයක් මෙන්න මේක දිහා බලන්න. Look at lead 2. QRS is normal, but look at the P wave. Look at the P wave. P wave is abnormal. The first thing you have to say, the P wave is abnormal. Right? So it is an atrial rhythm. P wave is abnormal. It is an atrial rhythm. Can you see the P wave? I have circled the P wave. It is abnormal. So this is an atrial rhythm. Here what is happening is, say this is the sinus node. There is atrium and the current again. Right? So this is suppressed. Atrium is running the show with this current coming from another place. Right? So this is called unifocal atrial tachycardia. So unifocal can එකතැනක්, multifocal can multiple තැන් වලින් it starts firing. Okay? All right. So remember definition, overarching principle. ඔක්කොටම අදාළ වෙන්නේ atrial rhythm is abnormal P, normal QRS, normal T. Abnormal P can be thousands and thousands of small broken up into pieces in atrial fibrillation, right? Irregular QRS complexes. A very nice sawtooth P wave due to this round and round circus-like current, merry-go-round-like current that occurs in atrial flutter, or this sort of inverted P or multiple P wave morphologies you see in atrial tachycardia or multifocal atrial tachycardia, where they usually cause a tachycardia as a result as well. Right. Now, Sajit has asked a very important question, which I will repeat, right? Why is atrial fibrillation different from multifocal atrial tachycardia? Now, all of you think of that question. It's a very important question. Why does atrial fibrillation differ from multifocal atrial tachycardia? Why? It's a very simple answer actually. Multifocal atrial tachycardia, there are only 3 or 4 abnormal firing places, right? 3 or 4 abnormal firing places. And that's why it still gives this irregular, can you see this irregular RR or irregular rhythm? Atrial fibrillation has thousands and 10,000s of abnormal foci firing. Multifocal atrial tachycardia only has 3 or 4. This has about 1,000 or 10,000 foci. So that's the difference. That's why this P wave is broken up into thousands and 10,000s of segments. Here it is like 3 or 4 because it's firing in 3 or 4 places only. Right? That is the difference between AF and MAT. Hari. Then බලමු ආයි මේ තුනම 4 types: atrial rhythms, nodal rhythms, ventricular rhythms, and sinus rhythms. Sinus rhythm, normal P, normal QRS, normal T. Atrial rhythms, abnormal P, normal QRS, normal T, because it follows the usual stream. Nodal rhythm, no P or very small tiny retrograde P, which I will show you, right? Normal QRS, normal T. Ventricle, completely chaotic, odd-looking shaped QRS complex, AV dissociation, right? AV dissociation. Fine. Okay, right. 4 types of atrial rhythms I have taught you. Atrial fibrillation, irregular baseline, normal QRST, but irregular rhythm. Right. Then this one, flutter wave, usually regular, right? QRS complexes. One inverted P, odd looking P, atrial tachycardia. Multifocal atrial tachycardia. Multifocal atrial tachycardia also is sort of a simpler version of atrial fibrillation. Simpler. ඒකේ 3යි 4යි තියෙනවා. අරකේ 10,000ක් විතර තියෙනවා. Abnormal foci. And you still get an irregular rhythm in multifocal atrial tachycardia also. Hari. Mahesh is also asking a very good question. How does a ventricular rhythm differ from a third degree heart block? In both conditions, there is atrioventricular dissociation. The difference, Mahesh, is that in ventricular, so actually in a third degree heart block, it is a ventricular rhythm, right? It is a ventricular rhythm that you get. But in ventricular tachycardia, which is slightly different, you get a very fast ventricular rhythm. In third degree heart block, it is a slower ventricular rhythm. It's called escape ventricular rhythm. I'll teach this later when we talk about complete heart block. But that's a very good question. This is actually a ventricular rhythm that you get in heart block also. I'll teach that later. Hari. Then බලන්න මේකේ rhythm එක මොකක්ද කියලා. Look at lead 2. Look at lead 2. I'll give you 10 seconds to come up with the rhythm on this. Sanjay, AF is paroxysmal sum. It depends on the etiology. Right? So sometimes all these things are there and it's triggered by something. Maybe stress, maybe caffeine, infection. The abnormal current is there. It's not working, but when you sort of have the infection or something, it starts firing. That's why it's paroxysmal. Fine. Okay, yes, so Isuri has got the answer. It is a nodal rhythm, very good. So nodal rhythm, look at this now. QRS complex, normal. This is a T wave, not a P wave. Okay, not a P wave, it is a T wave. You can't see a P wave. Michael, lazy when the mataka tiyagana, nodal rhythm is essentially, what is it? Nodal rhythm is essentially no P, little bit normal QRS. මංකව කලාතුරකින් නෙමෙයි ඇත්තටම මේ retrograde P කියලා එකක් තියෙනවා කියලා, because a node is now driving the show, it sometimes goes this way මෙහෙම. ඒක තියෙනවා හරියම අමාරුයි. ඔගොල්ලෝ විශ්වාස කරන එක නැහැ. මෙන්න මෙතන තියෙන්නේ. It's best seen in V1. මේ මෙතන, can you, if you imagine this, very very difficult. මෙන්න මෙතන නිකන් උතන බලන්නකො ඔතන. මෙන්න මෙහෙම නිකන් ඔහොම එකක් පේනවද? Right, so this is the retrograde P. මෙන්න මෙතන තියෙන. ඕක තමයි retrograde P එක. දැන් උඹලා තේරෙනවද උඹලා කොහොමදත් මේ මහා ආදිස්සිය ඔස්කියට ඉන්නකොට ඕක හොය හොය ඉන්න බෑ කියලා. Obviously you will not see this, right? So that is this small notch here is the retrograde P. Right, that small notch is a retrograde P. Right, that small notch is a retrograde. Okay. Okay, so many people have issues in identifying the P wave from the T wave. Okay, so that's rather, yeah, it's a common question that people have, right? One is a shape. Now use the T wave is taller than the P wave, okay? And is the first positive deflection after was complex. So T wave is the first positive deflection after the the QRS complex. Okay, that is how you diagnose the T wave. Now, ඔතන මෙන්න මෙහෙම මේ වගේ තැන්වල ඕක අමාරු වෙන්න පුළුවන්. දැන් මේක T wave ද P wave ද කියලා හොයන්නේ කොහොමද? Right? Then, but you can see me. It is a first positive deflection. දැන් මෙතන තමයි T wave එක තියෙන්නේ. ඉතින් this is the T wave. First එක කියන්නේ negative වගේ deflection එකක් තියෙන්නේ. This is the P wave. This is a sawtooth P wave. Okay, experience වලින් එනවා බය වෙන්න. ECG බලනකොට ඔක පුළුවන් වෙනවා. සමහර ටිකක් අමාරුයි. හරි. So in this ECG, this is the T wave, this is the P wave. So the T wave is the first deflection. Might be positive, might be negative after the QRS complex. Immediately after the QRS complex. So this is the T wave here. Hurry. Okay. So nodal rhythm, no P, normal QRS, normal T. You might get this retrograde P, which is very, very difficult to spot, as you can obviously imagine. Okay, what is the rhythm here? Here you can see මේ QRS එක හොඳටම මඤ්ඤං නේද? It's completely off. Can you see that? It's completely off. Here, here, completely off. So all these three are then ventricular rhythms. All these three are ventricular rhythms. So what are the features of a ventricular rhythm? Broad abnormal QRS. Broad abnormal QRS. Okay. Broad abnormal QRS. Broad abnormal QRS. And AV dissociation, you might not see it in every ECG. AV dissociation, have ECG campaign. Broad QRS, have ECG campaign. Broad QRS. Broad QRS. Right. There is a question in multifocal atrial tachycardia, P wave is not absent, right? You will get some sort of P wave. Then maybe make a multifocal atrial tachycardia. Make a P wave එකක් තියෙනවා. maybe හැම එකේම මේ මොකක් හරි P wave එකක් තියෙනවා. හැබැයි ඒක abnormal, tall, short, inverted, whatever එක එක විදියට. Harshan is asking, is there a usual cutoff rate for ECG to consider F? No, cutoff rate එකක් නැහැ Harshan. Atrial fibrillation can be slow or fast. The rate has nothing to do with it, right? The rate has nothing to do with it. It is just the appearance of the ECG like this, right? The rate has nothing to do. So you have fast AF, slow AF. I will teach this when you talk about tachyarrhythmias when you come to Professor Oren's emergency medicine. But essentially, the rate has nothing to do with the diagnosis of AF. It can be slow or fast or whatever. Essentially, AF means abnormal P, normal QRS. Abnormal P is irregular baseline, right? That is what you get. So in a ventricular rhythm, then very abnormal looking QRS complex. When it is like this, it is called ventricular tachycardia. So it's regular in either. shape So this is called monomorphic. Monomorphic shape. So this is called a monomorphic VT, ventricular tachycardia. Tachycardia because it's fast, obviously, right? This is called polymorphic VT because regular it's regular, but the some are tall, some are short. This is called polymorphic VT. Polymorphic VT. And this is VF. Right? This is VF. So monomorphic VT, polymorphic VT, and ventricular fibrillation. These are all ventricular tachycardias. Ignore this one, this is a bit too much for you. Right? These are all VT. See, it's a normal looking QRS complex. Again, okay, abnormal, broad looking. Here, lead to best place to see. Abnormal, broad looking QRS, all ventricular rhythms. Right. a slight word of caution, write this down. Ventricular rhythms are not the only cause of a broad QRS. Broad or slightly abnormal looking QRS, right? I want you to think of another cause, two more causes, and tell me, right? Tomorrow. That's just a slight word of caution. හරිනේ. හරි දැන් මේ rhythm analysis වලින් තියෙන ප්‍රශ්නෙට sorry. So බින්දුල yes, polymorphic VT is also called Torsades de points. Okay, polymorphic VT මේ උඩ තියෙන එක is also called Torsades de points. Torsades. Okay, it's also called Torsades de points. Okay, it looks like a twisted ribbon. Torsades de points means a twisted ribbon. Looks like a twisted ribbon. Right. Now, please ask any questions if you have anything on rhythm analysis, which is the most difficult thing in ECG. The rest is very easy. The rest of the ECG is very, very bloody easy. This is the difficult part. So, as an undergraduate, you need to know 4 types of atrial rhythms: AF, atrial flutter, multifocal or unifocal atrial tachycardia, right? Those are the 4, right? Those are the 4. Then nodal rhythm, no P, normal QRS, might see this retrograde P. Okay. Ventricular rhythms are broad QRS complexes, abnormal looking QRS complexes, ventricular tachycardia, polymorphic ventricular tachycardia, and ventricular fibrillation. Right? These are all ventricular tachycardias. Sorry. Make a very colorable part, don't worry about that. This ventricular tachycardia. This again ventricular tachycardia. Again ventricular tachycardia. Ventricular tachycardia, however, is not the only reason for broad abnormal looking QRSs. There are some other reasons. Some toxins can cause broad abnormal QRS complexes. Certain other problems can cause. So just find out what those are for home. Hi, Prashna. 1 minute for questions and we move on to the last part. Yeah. So, yeah, can I explain unifocal atrial tachycardia? Yes. Yeah. So unifocal atrial tachycardia is essentially just one place in the atrium firing abnormally. Say this is the sinus node. Usually the atrium depolarizes like this, no? Right. So you get a normal P, normal QRS. When you have unifocal atrial tachycardia, there is an abnormal focus in the atrium that is now running the show, which is depolarizing this way. So actually the P is abnormal and inverted. It's going the other way. That's the basis for it. And then in multifocal, you get many morphologies because there are 3 or 4 places where that's firing out. Right. Okay. The next question is, what is the difference between unifocal, polymorphic VT is regular, ne? Then there is a pattern to it. Usekai, kotekai, kotekai, usekai, kotekai, kotekai. There is a pattern to it. Polymorphic VT. Okay. VF is completely chaotic. කිසිම relationship එකක් නෑ මේ ඔහේ උඩ හොම යනවනේ. It's very chaotic. This still has බලනකොට ලස්සනයිනේ polymorphic VT. There is a nice, looks nice. Same shapes but some are tall, some are short. මෙතන පුදුම කැතයි. It's completely abnormal. There are places coming here and there. Okay, that is the difference. Okay, another good question from Shalit. Does the SA node work in atrial tachycardia? Not usually, it is suppressed, Shalit. So therefore, the only thing running the show is this abnormal atrial thing. Yeah. And usually, yes, unifocal atrial tachycardia starts from the left side. That is most commonly, that is where the problem is, most commonly. So it is usually negative, P. Well, Saman in this way is positive, now it's going the other way. So the P wave is usually negative. Yeah. මේක හොඳට තේරුම් ගන්න. හරිද? Very important. Any other questions? Okay. Right. I'm happy to stop in the middle if you have any questions in the middle also. Right? Okay. Hari. Right. So now let's go to conduction. Conduction. So we have done the rate, axis, rhythm, and now we go to conduction. So conduction is what we are doing is we are examining. So this is the onset of the electrical impulse. Are there any blocks along the way? Are there blocks along the way? The two commonest places where you can get blocks are, one is the AV node, two is the, so this is the AV node, two is the bundle branches. So those are the two common places where you can get blocks, AV node or bundle branches. Somebody asked the question, oh, what is atrioventricular reentrant tachycardia and atrioventricular nodal reentrant tachycardia? Don't worry about that for the moment. Hari. Essentially, both are sort of around the AV node problems, right? Hari? So don't worry about that yet. I'll teach that later. ඒක ඔයගොල්ලෝ දැනගන්න අත්‍යවශ්‍යම දෙයක්ුත් නෙවෙයි, but I will teach you later. Right. So another very good question, can we call a rhythm as a sinus rhythm even if there are ectopics? So yes, you can, and that is important. That's a very important question. Ectopics are occasional problems. So you can say this is sinus rhythm, but there are occasional ectopics, right? And there are ways of actually counting, say 20% ectopic or 30% ectopic killer, ways of counting also. Good question. Right. So in conduction analysis, we are looking for blocks. Now at the AV node, there are three types of blocks. First degree block, second degree block, and third degree block. So first degree block, second degree block, third degree block, three types of blocks. Right. First, now write this down very, very carefully. First degree block, all the P waves are conducted. So this is මේ හරිය තමයි AV node එක තියෙන්නේ. AV node එක හරි. All the P waves are conducted. ඔක්කොම යනවා. ඔක්කොම යනවා කිසි කරදරයක් නැතුව ඔක්කොම එනවා. All the P waves go. All the P waves go. Right? But there is a delay. මේ පොඩි delay එකක් තියෙනවා. The PR interval is prolonged. So that is by definition a first degree AV block. What is the definition? All P waves are conducted. All P waves are conducted. But the PR interval is prolonged because there's a delay in conduction between the atria and the ventricles. So first degree heart block, all P waves go long PR interval, prolonged PR interval. Hari. Second degree block. The definition of a second degree block. Some P waves go make a gear. Hari. Make a gear. Some P waves don't. So the definition of a second degree block is some P waves go, some P waves don't go. That's the headline for a second degree block. Some P waves go, some P waves don't go. Hey, but make a second degree block. Yeah. Some P waves go, some P waves go, some P waves don't go. Second degree block. That is the headline definition of a second degree block. Some P waves go, some P waves don't go. You can clearly see that. There are three types of second degree blocks. Three types of second degree blocks. Number one, the PR interval progressively increases before the misbeat. That's called Mobitz type 1 second degree block. The PR interval progressively prolongs before the BIST beat. That is also called Venn-key back phenomenon. Venn-key back phenomenon. Okay, so that is progressive prolongation of the PR interval. So question is in AB nodal box. So in first degree block, all P waves go. Okay? So person will ask this question. In first degree, all P waves go. In second degree block, some go, some don't. I don't know what the basis of that is. It's a complicated electrophysiological mechanism. Don't worry about it. Right? Don't worry about it. But some go, some don't. Yeah? Some go, some don't. Some go, some don't. Right? Progressive prolongation of the PR interval before is type 1. Methana, there is no progressive prolongation of the PR interval. It's the same. Ne? That's type 2. So Morbid's type 1, progressive prolongation of the PR interval before the miss. No such thing. So it has to qualify as a second degree block. So what is the qualification as a second degree block? Some P waves go, some P waves don't. Then is there progressive prolongation of PR interval before the miss? Yes. Answer is first degree. No, it is second degree. Right? Type 3 is something like this. Unfortunately, I don't have an ECG. I should have put that on. P wave, P wave, P wave, QRS complex. P wave, P wave, P wave, QRS complex. P wave, P wave, P wave, QRS complex. Okay. Some P waves go, some P waves don't. Second degree block. Make a gear, ituru deka gihilla naha. So this is type 3, which is called a fixed, it's called a ratio block. So this is a 3 to 1. 3 to 1. Ratio block. So you have 3 P waves to 1 QRS complex. Right. Then balannai. So AB nodal blocks, first degree block, by definition, all P waves go. Second degree block, some P waves go, some P waves don't. Some P waves go, some P waves go, some P waves go. This P wave doesn't go. This goes, this goes, this doesn't go. This goes, but these two doesn't go. So it's all second degree. There are 3 types. Then progressive prolongation of the PR interval before the misbeat is a Venn-key back called type 1. Type 2 is no such increase in the PR interval. Type 3 is a fixed ratio like 3 to 1 or 4 to 1 or 2 to 1 or whatever it is. Right? So that is the 3 types of second degree blocks. Final one. Third degree block. None of the P waves go. None of the P waves go. එකක්වත් යන්නේ නැහැ. නෝන ලස්සට බලන්න. First degree block ඔක්කොම ගියා. Second degree block සමහර ඒවා ගියා, සමහර ඒවා ගියේ නැහැ. හරි? සමහර ඒවා ගියේ නැහැ. හරි? Third degree block, none of them go. None of them go. Vinod Prasant is asking important question. How do you differentiate ratio block from atrial flutter? Yes, very good question. It's all by the shape of the P wave, Vinod Prasant. So in atrial flutter, the P wave is the clue. P wave is sawtooth, right? In the other one, there is no such thing. It's a normal P wave, right? Normal P wave. Even in this lama, it is essentially a 2 to 1 block tamai. It's atrial flutter with 2 to 1 block in this one. Right? Here it is sinus rhythm with 2 to 1 block. Maybe 3 to 1 block. Sinus rhythm with 2 to 1 block. Sorry. Is there any particular lead that we look at conduction? Again, lead 2. So write that down. For rhythm and conduction, the best lead to look at is lead 2. Right? Right. So coming back to third degree block. Third degree block, what is the definition of third degree block? None of the P waves go. So what happens then? එකක්වත් යන්නේ නැති නිසා the ventricle starts generating its own rhythm that is called escape ventricular rhythm. Escape. ඒක tachycardia එකක් නෙවෙයි. ඒක escape එකක්. නිකන් යන්තම් වැඩ කරනවා. It starts working. But we already know by definition, if there is a current starting in the ventricle, what happens to the QRS complex? It is abnormally shaped. නේද මේ QRS ටික හරි අමුතුයි. So the escape rhythm also has a broad abnormal looking QRS. The only difference from ventricular tachycardia or whatever is that this is much slower. Maybe about say 30 or maybe 30 to 40 or less sometimes also. Very slow. That is slow. So in third degree block, none of the P waves are conducted. Ventricle starts generating its own escape ventricular rhythm, which is much slower, but in essence, it is a broad QRS complex, as we know, right? A broad QRS complex. But does the atrium stop firing? No, it doesn't. උඩ ප්‍රශ්නෙකුත් නැහැනේ. අර මැදදී එන්නේ නැති එක තමයි ප්‍රශ්නේ. මැදදී එන්නේ නැති එක තමයි ප්‍රශ්නේ. හරි? හරි, එතකොට මොකද වෙන්නේ? එන්නේ නැති එක තමයි ප්‍රශ්නේ. Then what happens is the P wave also comes at regular intervals. ඒක දන්නේ නැනේ පල්ලෙහා මොනවා වෙනවද කියලා. හරි? හරි. Okay. It also comes at regular intervals, and there is AV dissociation. AV dissociation. The P wave and the QRS, there is no relationship. උඩ එක්කෙනා උඩ ඕන විදිහට වැඩ කරනවා, යට එක්කෙනා උඩ ඕන විදිහට වැඩ කරනවා. Right? No relationship. That is what happens. So the key features of a third degree heart block, abnormal QRS, broad abnormal QRS complexes, right? Abnormal looking QRS complexes. And yes, they look the same. Yes, they look the same most of the time, right? QRS complexes. And then P waves also coming, but dissociated. They come in various places. There is no relationship, right? No relationship. No relationship. But they are there. So that is the third degree heart block. And bradycardia is around, say, 30, 40 or even less sometimes. Right. So those are the types of AV blocks. To revise then, first degree, all P waves are conducted. Second degree, some P waves are conducted, some P waves are not conducted. Third degree is that, third degree is none of the P waves are conducted and the ventricle starts generating its own impulse. And Sanjay has asked a very important question. Why in third degree does the ventricular firing dominate? Two reasons. I told you that anything starting in the ventricles cannot go up. They cannot go up. So they can't depolarize the whole heart because there is a large fibrous tissue which separates the atria and the ventricles. But the AV node is intact. So therefore it continues to fire. Right? That's what happens. Okay. Binu is asking another very important question. Can a complete heart block occur with a narrow QRS complex? හරි දැන් මම මේක උගන්වන්න ලෑස්තිලා හිටියේ නැහැ තේරුම් නැත්නම් වැඩි කලබල වෙන්න එපා but I will explain because Vinu has asked this question. Now just I'm going to draw two hearts now. Right. So this is complete heart block A, example A. This is complete heart block example B. Right. Okay. Fine. Okay. Right. In this heart, right, the escape rhythm is starting from here. Okay. This heart, the escape rhythm is starting from here. That happens in very severe disease. In this heart, the escape heart is more closer to normal, young heart. So it's starting close here. So what happens to the width of the QRS complex, A and B? What will be broader? What will be closer to normal? In other words, what will be closer to normal, A or B? The escape rhythm, the shape of the escape rhythm, what will be closer to normal? It will be A because it's closer. So it can just sometimes follow the same pathway at least. But it still be a little broad beneva. Hari? Here it is going to be very, very abnormal because it's starting in a Thanikara Hadda Kaleka. Hari? So the QRS is very, very broad in this one. And actually, we know the breadth or the size of the QRS complex determines prognosis, right? So essentially, this fellow has a better prognosis. He has a narrower-ish QRS complex. He has a better prognosis, whereas this guy has a very poor prognosis. So yes, the QRS complex can be narrow, but not completely normal. It can be, so the smaller the width of the QRS complex, it is better. Right? That's because you asked the question, but broad tamai, but broad venna kashal, because it starts more distally. The escape rhythm starts more distally. Hari. Okay. If you don't understand other people, don't worry. It's not important for you. For you, complete hard block, escape rhythm, broad QRs. But the breadth of the QRs can change based on where exactly the escape rhythm starts from. But all of them are broad. Hari. The rest is very easy. Bundle branch blocks. Just remember these two things. Right bundle branch block. So for bundle branch blocks, look at V1 and V6. So all this time we have been looking at lead V2, V1 and V6, you look for bundle branch blocks. And remember the mnemonic, William Marrow. William Marrow. Okay, so this is V1. Okay, and this is V6. In a left bundle branch block, either V1 or V6 में देखा मत ये नोट है V1 W shape, V6 M shape. In a right bundle branch block, V1 M shaped, V6 W shape. ඔය දෙකම තියෙන්න ඕනේ දෙකෙන් එකක් තිබ්බත් ඇති. දැන් මේ example එක බලන්න. Sorry. මේ example එක බලුවොත් this is a right bundle block. Can you see? M shape in V1 මේ. M shape in V1 is a මෙතන මේ right bundle branch block. In this M shape in V6. M shape in V6 is a L, William, left bundle branch block. Left bundle. The other thing to remember is there'll be in a left bundle make a very deep RS wave, S wave, make a S wave, make deep S wave, this one. In a left bundle branch, you'll also have a very deep S wave, like this. And William Marrow. So V6 will be M-shaped. M. That's how you differentiate left bundle branch block from right bundle branch. Okay, fine. Yes. So there is a question about ventricular tachycardia again, which I will answer now. So in ventricular tachycardia, I told you that the QRS complex is tachycardia. It is completely abnormal and irregular. And there's atrioventricular dissociation. So the answer to this question, in VT, does the SA node function and give PFs? Yes, it does. But yeah, they're all buried here. Because the but it is there. It is there. Yes. Sometimes you see it, but not always. Okay, so rhythms and conduction. Any questions? So there are rhythms sinus rhythm, atrial rhythms 4, atrial flutter, fibrillation, atrial tachycardia, unifocal and multifocal, nodal tachycardia, and ventricular tachycardia. Right? Those are the types of rhythms. Yeah. And then you have conduction problems: first degree heart block, second degree heart block, third degree heart block, left bundle branch block, and right bundle branch block. Right.
Excuse me, sir.
Yes, sir.
In
Yeah.
second degree heart block, in the morbid type 2, can we have irregular, regularly regular rhythm in heart rate?
You can have anything. You can, because say, for example, if this is, say, this block is occurring regularly, you will have it. Yes. Yeah. Regularly, irregular. Yeah. So tunai miss or something like that. You can get it. Yeah.
Thank you, sir.
Okay. Right. How can you differentiate Morbid's type 2 and complete heart block? Morbid's type 2, this one, and complete heart block. Any answers to that question? You guys can answer it. Now, if you have, how do you differentiate Morbid's type 2? That's a very good question. It's a very common question as well, as students often have. How do you differentiate Morbid's type 2 from complete heart block? Kaurikian? One, obviously in complete heart block, the QRS complex will be broad. The QRS complex. Escape rhythm, no. So, the QRS complex will be broader. Number one, difference. What is the other difference? Which is very, very important. May register alat varaddano samaragata. Amala godak kelada varaddano. What is the difference? May balannako make P wave QRS, there is no relationship. The PR interval changes. I'm a velema. But here it doesn't. Right? In a type 2, type 1 එක වෙනස්, right? Because it prolongs it. Here it doesn't change. Right? It doesn't change. So in a third degree heart block, the QRS complex is broader and there is absolutely no relationship between the P and the QRS. කිසිම සම්බන්ධයක් නැහැ. The PR interval changes from place to place to place. Here it's fixed. Those are the two differences between a type 2 second degree block and a third degree heart. That's a very difficult thing because I register alat godak kelada varaddana ekak. Eka postgraduate issue ekak. Right. So there are some other questions. Imalka is asking, can we predict whether ECG, whether QRS will convert to a pulse? No, you can't do that. Imalka, you can't predict whether a QRS will convert into a pulse by looking at a ECG. You can't do that. Samadhi will have electrical activity but no pulse. So that is difficult to say. If unifocal atrial tachycardia arises from the Maru Prastum, very good questions actually. This shows that you have tried to understand this, which I am happy about. Unifocal atrial tachycardia, can it arise from the right? It arises usually from the right atrium. Can you differentiate? Yeah, it can rarely arise from the right atrium, but still there will be some. It's very, very difficult. Hari amarui. If electrophysiologist lada vitarai pain, but there will be some sort of abnormal shape, right? Samahat oka nikam bifid wage wenna pula amutu shape ekak enawa, even if it arises from the right atrium. Right? But it's very, very difficult and you usually need a electrophysiologist to differentiate those type of things. Right. Bundle branch blocks, yes, you can remember the mnemonics. You don't need to remember any other criteria, right? For bundle branch blocks. William Marrow, right. Okay. Any other questions? Right. I think that we should stop here for the day. The reason being now poddai tiyenne, but I think ubala punchi molawalata මේ ටික ඇති අදට කියලා, right? There is no rush to finish it, not like your exam is next week, right? So there is no rush to finish it. I think this is enough for today. There is a little bit more which we'll do tomorrow with the x-rays. හරි? Well, X-rays are much easier. X-ray එක බැලුවම නිකන් පේනවනේ මොකක්ද ඕක තියෙන්නේ කියලා. This is a bit more challenging, so I will stop here. Right. Now, please ask any further questions if you have, and I want you to read this today. හරි මේක මේ හෙට අනිද්දා බැරීමක් නැහැ. I want you to do review this. So I send you the presentation now. Saranga, I'll send it to you and then you distribute it. I assume, yeah, you have a group also name. Batch group. Yeah. Okay. Yeah. So rejuvenate that. I'll put it on that and I'll send to you also. Hari. Okay. Right. So today, yeah, I'll tell you. Just give me a minute. So today, what we have done is, Lamai, we have discussed ECG interpretation. Number one, what are the key steps in looking at ECG? So the first thing is understanding the leads, calculating the rate, which I didn't go in detail today. Looking at the axis rhythm, sinus rhythm, atrial rhythm, nodal rhythm, ventricular rhythm. Within atrial rhythms, we saw atrial fibrillation, flutter, unifocal atrial tachycardia, multifocal atrial tachycardia. Finished. Then we talked about nodal rhythm. Nodal rhythms, obviously, we talked about NOP, QRS and T. Then ventricular rhythms, broad abnormal looking QRS complexes, atrial ventricular dissociation. Somebody asked a very good question. Can you see the P waves? But they are buried usually and you don't see them, but they are there. Right. Then conduction abnormalities is next. We talked about AV nodal blocks, first degree, second degree, 3 types, and third degree blocks. Somebody is a very good, very, very important question, which is something that even postgraduates get wrong. Second degree Mobitz type 2 and third degree block, how you differentiate those two. We will do practical examples of these also when you come to your appointments, but this is just a basic thing because I know you haven't been taught this before, right? Hari. Then we talk, those are things we talk about, left bundle branch block, right bundle branch blocks. Okay. Hari. Somebody has asked a question. Will I do what do I think? Yes, of course we will do myocardial infarction and hypertrophy anamana okkoma. That will be tomorrow. Right. Now, yes, wrong lead placement can cause very weird looking ECGs. I will show some of them to you later, right? There are ways to differentiate wrong lead placement, right? But those are a bit advanced things. I want you to just focus on the basics first. So Shenal, yes, you can use rate to differentiate between flutter and a 2-to-1 block. Flutter, usually the rate is very high, 150 to 200. Yeah. Yeah. But otherwise, go by the shape. Go by the shape. Another question, in third degree block, is a ventricular rhythm itself regular? Yes, it is. The escape rhythm is regular. Yes. If there are ectopics, how do you calculate the rate? If there are ectopics, you get a normal looking place and calculate the rate. That is what you do. Very normal looking place and calculate the rate. Any other? So for tomorrow, we will do the last part, that is looking at individual waveforms and segments, right? Individual waveforms and segments. So for example, looking at the P wave, looking at the QRS complex, looking at the ST segment, there will see your MIs, right? LVH vage deval, looking at the T wave, tall T waves, inverted T wave, that sort of thing. What does it mean? That is easy. Right? The difficult part is this conduction and the rhythm. More than the conduction is the rhythm. Right? Saranga, tomorrow same time is okay. I think I should be okay.
Okay, sir.
Yeah. Hari, okay, I will see you tomorrow then, where we do the rest of this, which is very simple, half an hour, and then X-rays. Yeah.
Okay, sir. Thank you.
Okay, right.
Thank you, sir.
Thank you.
Thank you, sir.
Thank you, sir.
Thank you, sir.